Kia ora, welcome to this session, and we're going to be talking about reentrant tachycardias. We use the term supraventricular tachycardia in the general sense to describe any tachycardia with its origin above the atrioventricular line. This means that atrial fibrillation with a rapid ventricular response could be described as an SVT. We use the term paroxysmal SVT more specifically. It describes a sudden onset of SVT with no clear evidence of its origin. In other words, there's not going to be a P wave that can be seen despite the supraventricular origin of the rhythm. From an electrophysiological point of view, this is most likely because the atrial activity is going to be buried somewhere in the QRS complex. A PSVT is often caused by a re-entry circuit. These can occur in the atria or the AV node. If the AV node is the culprit, the likelihood of seeing a P wave is very remote. So the rest of this presentation is going to focus on these PSVTs that are caused by an atrioventricular re-entry circuit. Re-entry circuits occur in a discrete, small block of tissue. This tissue is going to be characterized by two parallel pathways, and each of these has a distinct electrophysiological property. One side or one arm of this pathway is going to be fast to conduct a signal, but very slow to repolarize, and we call this path A. The other arm, the parallel arm, is going to be slow to conduct, but faster to polarize, and this is known as path B. So let's look at how this might work. The signal reaches path A and B at the same time. Path A will be faster to conduct, and the signal is going to reach the far arm of the circuit first. From here, the signal will follow the nodal tissue into the common bundle and is going to go on to depolarize the ventricles. As path B hasn't fully depolarized yet, the signal from path A will travel in the wrong direction up this arm. This is called retrograde conduction. It will encounter the signal coming down the B path in the opposite direction, and the signals are going to stop where they meet. There's nowhere for them to go. You might portray this as a signal having been cancelled. Now both paths A and B are going to repolarize, and the usual depolarization sequence will repeat the event over and over again. You'll note that path B may repolarize slightly before path A because it is the faster of the repolarization circuits. But this is of little consequence in normal circumstances because path A will still have time to fully repolarize before the next signal arrives. So both arms get signals initiated at the same time, but path A is so much faster going on to initiate the common bundle. In the meantime, some retrograde conduction up path B cancels the signal coming down. Both arms will repolarize and be ready to repeat the same signal. So in normal circumstances, this is not an issue. And once more, into path A and B, successful in path A in terms of initiating a ventricular response, and then cancels out the signal coming down path B. So this isn't an issue for most occasions, but the somewhat unique setup in this pathway can result in what's known as a re-entry phenomenon. So the final part of this presentation relates to path B's fast repolarization characteristics and what might happen should an early signal reach path B before path A is repolarized. So let's look at what happens when a premature atrial contraction arrives at the wrong moment. And for this moment to be wrong, the signal must reach path B before path A has repolarized. Because path A hasn't repolarized sufficiently, it can't respond. And path B gets a head start, and it's going to be the first to produce a signal that's going to reach the far arm of the circuit. From here, the signal can follow the nodal tissue down to the common bundle and go on to depolarize the ventricles, albeit a tad early. The slower transmission in path B will allow time for path A to fully repolarize, so it's going to be ready to go when the signal from path B gets down to where it joins at the nodal tissue. So the antegrade or the forward moving signal from path B is going to initiate a response in path A, and retrograde or backwards transmission occurs. When this reaches the top of path A, it's going to meet up with path B, and you'll recall that has a faster repolarization time, hence it's ready to go again. And so this has set up a cyclic re-entry. So the nature of the circuit causes rapid re-entry rates, somewhere between 140 and maybe 260 beats a minute. The distal part of the AV node and the bundle of His is quite capable of passing these fast rates down to the ventricles, and we end up with these very fast ventricular rates as a result. So let's just quickly review the ECG characteristics of the AV nodal reentry tachycardias. From a rate point of view, we tend to see ventricular rates of between 140 and 260, and at those faster rates, we're quite likely to see some level of compromise associated with this. The regularity of these rhythms is very marked in the R to R intervals. You could basically use it as a ruler. The other thing about it is that it tends to be very abrupt in both onset and termination. In terms of P waves, there are none defined, which means the question of whether there's a PR interval or not becomes a moot point. The QRSs tend to be narrow because we're using a normal nodal pathway to reach the ventricles. However, if there is a concurrent bundle branch block, this may widen the QRS, but we'll go into this more in a different session. So this just leaves the question of management. Management normally responds to the severity of the symptoms, so that's our guiding principle. And so we'd avoid invasive therapy if there's no signs of serious compromise or in a situation where non-invasive therapies would be just as effective. The theory behind all the management strategies is to stop the re-entry circuit, and we do this by elongating the absolute refractory period of both arms. So essentially, neither arm can transmit, and hopefully path A will repolarize in time to become the dominant path again. As the AV node has a large concentration of parasympathetic nerve endings, it's possible to induce a complete blockade in the AV node. And it's this blockade that's going to allow both of the arms to repolarize, and thus the antegrade conduction can start again in path A. The non-invasive way of doing this is via vasovagal maneuvers such as the Valsalva. Where this is unsuccessful and the patient remains moderately compromised, a rapid bolus of IV adenosine will cause a temporary AV blockade to achieve the chemical cardioversion. And finally, for those patients who are severely compromised, and particularly where there's an alteration in their level of consciousness, we can use electrocardioversion in the way of a synchronized shock to achieve the same thing. I hope this has been useful. If you have any questions, don't hesitate to get hold of me. In the meantime, ka kite.